Welcome to the ATSOP dinner 2019, and thank you for accepting the invite. And most of you I see have made an effort to come dressed, and I'm very, very proud of the effort you take, and I give you all a big hand.
Well, I appreciate you giving me the opportunity to talk to you all tonight. This is Chad Eckert. He's an engineer that works with J&J and Epicon and has helped develop a model that will hopefully help us better understand what the causes of air leaks are in surgery of the chest and some of the devices and how they can impact and reduce this complication. And my job tonight is to really shed some light on the clinical aspects of air leaks and how it impacts us and our patients. Start the slides, and I'm just going to give a sort of a clinical overview, and then I'll let Chad, who's much smarter than I am, talk about this model that hopefully in the future we can use going forward to help newer surgeons learn and understand the causes of air leaks. So postoperative air leaks, as most of the surgeons in this room know, is probably one of the, it's not a major complication, but it's probably the most common problem in thoracic surgery that keep our patients in the hospital for a long period of time. And what we do at the time of surgery and after the time of surgery can influence how the patient recovers from that air leak. Most of our air leaks are clinically insignificant. However, there's a significant percentage, at least 10%, that are clinically significant and prolong the stay of our patients in the hospital. And generally these are associated with worse outcomes. There tends to be more postoperative complications in these patients. It certainly prolongs the stay, and if the stay is prolonged and the interventions are increased, the higher the cost to take care of these patients. So the predictors, we are all familiar with some predictors of air leaks. The incidence, duration of postoperative air leaks are not necessarily a consequence of surgical variables. I do believe that there are some surgical variables that influence this, but not all of them. And there are some characteristics within our patients that help identify which patients are likely to have air leaks and which patients are not, such as the classic COPD patient or the emphysematous patient, those that have a number of adhesions or redo surgery in patients, upper lobectomies or bilobectomies where you end up having a risk of a space defect has a higher likelihood of an air leak. And then patients with diabetes, patients on corticosteroids, patients who are smokers and have previous infections such as TB, all can be increased risk factors for air leaks. So how does this impact our patients? How does this impact the healthcare system as a whole? And I bring your attention to this MedPAR study, or this analysis that was gathered from the CMS database. And they looked at patients that are high risk for air leaks, those that have lobectomies and those that have lung volume reduction surgery. And we know that if the air leak prolongs, particularly longer than 7 days, this increases the morbidity, increases the necessary interventions to deal with these air leaks, and then thus increases the cost. So they go into this detailed analysis even further and divide these patients who've had lung volume reduction, segmentectomy, or lobectomy into separate groups. Those that have group A, which is no air leak, and group B that have an air leak, okay? And then they divide the group B into two separate groups with the patients who have an air leak that lasts for less than 7 days, and then also a group that has an air leak greater than 7 days. And you can see the financial impact to the healthcare system as a whole. You can see that patients who have an air leak greater than 7 days, there's an increased cost of almost $115,000. So it's a substantial impact financially to the healthcare system and our patients' care as a whole. So how can we address this and hopefully reduce this? And I'm going to just briefly talk about a little bit of the treatment and what my philosophy is around air leaks. But I think the most we can do is use good surgical practice to influence whether the air leak is going to be likely or not. And I think best practices at the time of surgery is your best hope to have a reduced air leak. But there are alternatives after you've operated and you find a patient who has an air leak. What we're hoping to do with this model is help understand the causes of air leaks at the time of surgery, how these products that companies offer us to staple the lung and seal the lung impact air leaks. And that's what I'm going to ask Chad Eckert to talk to you about, and where this model is going forward in the future to help us and younger surgeons understand where leaks come from and what we can do about them as we go forward. And I'm not going to go into all the necessary treatments that we have available to us as surgeons once we identify a patient with a prolonged air leak, because I think we all sort of understand what's out there, and I don't want to take the time to go through that. But I'll let Chad, who's got a lot more complicated presentation to give you, so I think he needs a little bit more time than me. Chad?
So the topic for debate today is, what do you do if you have lung cancer? Is Sub Lobar resection the same as SBRT? On the side of Sub Lobar resection will be presented by the one and only Sihoe. It has been long debated that the radiation oncologists hide in their bunkers, but today, the one and only radiation oncologist dared to step out of it. The one and only Russel Hales. So we have 3 judges tonight.
You'll be against it, but that's
2 are pulmonologists by profession. Ladies and gentlemen, let's welcome the judges for tonight, Dr. Lazaro, Dr. Kyle Hogarth, and Dr. Rajiv Goyal. Give them a big hand. Thank you, ladies. The judges are ready?
We are very ready.
So, on the side of Sub Lobar resection, the surgical team will say that Sub Lobar resection any day is better than SBRT. So, defend the topic, Dr. Alan C. Your time starts now. Thank you.
Your Honors, ladies and gentlemen of the jury, in this case of the people versus SBRT, the prosecution will demonstrate beyond a reasonable doubt that it is the surgeons who have the motive, the means, and the opportunity to cure lung cancer. I call upon our first witness, me. Now, the reason I am a witness is because I happen to have been a patient last year. I suffered from a condition known as pes and swinus bursitis, for which my orthopedic surgeon gave me a steroid injection. Unfortunately, I also got Staph aureus, and that ended up with me having a very big abscess in my thigh, as you can see there in that photograph. 2 days after this photograph, I was having chills and rigors, a high temperature, and MRI showed I had a 30-centimeter abscess in my thigh. And at that point, another orthopedic surgeon offered me the opportunity. Either I could have repeated aspiration, which was less traumatic, Or I could have surgery. At that point, many questions flooded through my head, and I realized I was in the same position as a patient with early stage lung cancer. He could have SBRT, sounds less traumatic, or he could have surgery. And at that point, when deliberating which option, which route I should take, several questions came into my mind. The first question is, if I'm going ahead with one of these therapies, am I being treated for the right diagnosis? Now, consider if you are having SBRT. You only have SBRT if you've had a diagnosis confirmed cytologically. So you would have to have first radiological suspicion. But as we said 2 days ago, for radiology, CT, to suspect that you have an invasive carcinoma, the sensitivity and specificity of CT is not that high. If you're choosing to go SBRT, you could have your lesion missed. If it is suspicious, you still need FNA or endobronchial biopsy. And for those tests, if you have a small lesion or a GGO, the accuracy can be as low as 50%. Again, you run the risk of actually being misdiagnosed. And even if you were being treated with SBRT, and let's say in this modern day of target therapy and immunotherapy as adjuvant, does this give you adequate tissue for your genetic analysis? No. Whereas if you went for surgery with sub lobar resection, you can have all the tissue you want. And you will have absolute specificity in your diagnosis. So for that first question, no question. The second question that went through my mind as a patient was, if I had one of these therapies, am I getting adequate therapy? Now for that, when you're treating lung cancer, no question. It's a question of lymph nodes. Now, even with clinical stage 1A lung cancer, there is a small but significant proportion of patients who end up with unexpected N1 or N2 disease. How significant is this? If you don't pick up the lymph nodes, you are going to have a worse survival. Studies like this have proved it time and time again. There's a separation of survival curves. Does SBRT give you lymph node assessment? No. No. Nowhere near a certain biopsy. Look at this. If you do a wedge resection, for early stage lung cancer, it's nowhere near a lobectomy. But you combine the sub lobar resection with the lymph node dissection, you get survival that approaches that of lobectomy. Can SBRT do that? Again, no lymph nodes. No lymph nodes. So it doesn't offer you adequate treatment. And then comes the most important question of all. Does it give you the best outcome? If you're not giving adequate treatment, not surprisingly, you don't get the best outcomes. Now you have graphs like this, survival curves like this. Early on, maybe in your first 6 months, SBRT might give you equivalency to sublobar resection. Give it a few more months, so after half a year, the survival curves start to separate. And that's when you see surgery is the only option to give you a lasting cure. Don't just take one example. This is a systematic review not done not too long ago. 18 different prospective studies, and they conclude the same thing. At 1 year, equivalency. At 3 years, notice those numbers. 3-year overall survival with sublobar resection, 87%. With SBRT, 40-odd to 50-odd%. That's a big difference. And many other studies since then have reconfirmed that. National Cancer Database, over 100,000 patients. That graph speaks for itself. Massive separation in the survival curves. Here's another, the SEER database. This is published very recently. Massive separation of the survival curves. And then you have this. This is the US Veterans Administration. Recurrence rates. You can see there, sublobar resection, significantly less than SBRT. And they're, in those little forest graphs, they're on the right, in every single subcategory of patients. Although they didn't reach statistical significance, they all favor towards sublobar resection. So if you want cure of your cancer, there is only one way to go, ladies and gentlemen. Now, last but not least, Our opponents there, for the defense, will try and argue that SBRT gives you less harm. Is that really true? No. This is the reality, ladies and gentlemen. Surgery, a 1-inch wound, out of hospital in less than 48 hours. Normal life thereafter. Look at SBRT. Look at those radiological effects. Not just a few months, but years after surgery. Look at the effect that has. It's a lasting, permanent damage to the lung, and it's measurable. Now you have studies that say, oh, SBRT gives you less postoperative impairment. That's not what the results say. Look at that. After treatment for sub lobar resection, no difference in your functional capacity. Whereas with SBRT, here's a small but noticeable drop. And if you look at these combinations of these different studies, even where the studies have people in the surgery group who have more advanced disease, who have more comorbidities, when you compare these surgical patients with SBRT, you don't get any more harm or morbidity done to these patients. Surgery is just as safe, if not more so nowadays. Now, Tommy D'Amico wrote a little commentary on that particular paper, and he noticed various things that were better with surgery as we expect. But I want you, members of the jury, to pay attention to that first line. This is something our radiation defense team will not tell you. The harm for SBRT doesn't just come from the radiation. It comes from all the other things that lead up to the radiation, including biopsy. They need biopsy. So that's added morbidity. You need one of these techniques. Each one in themselves has a small but significant risk. And when you do these tests...
Excuse me, his time is up. It's been 7 minutes.
That's the kind of argument of the losing side. They only have an objection because they know they're losing. Thank you, Your Honor. If you have these biopsies with a diagnostic yield of only 50%, you will have repeat biopsies. And therefore, you will run the risk again and again of comorbidity, such as pneumothorax, such as chest drain insertion. Whereas a morbidity from surgery, we all know, nowadays, it's not 10 years ago, this surgery is very safe. So in conclusion, in every single question, whether you're diagnosing adequate treatment, best outcome, or less harm, everything is in favor of surgery. So after I asked those questions, in the end, what did I have? I had surgery, and I did very, very well. Thank you very much.
Come and sit where the radiation oncologist is.
I'm doing this out of pity.
Okay, in defense of SBRT, the one and only Dr. Russel Hales.
So I'll set a timer for you, okay? So you have only 5 minutes.
Yeah, those are the rules that the surgeons live by, aren't they? My time has not yet started. Let me say a few things about my costume before I start. Those of you may think I'm from the UK, but I'm actually from the US. And in the US, our national costume means that we value our hair tremendously. And although I don't look like Trump, let the clock start. Democracy is to have 2 wolves and a lamb voting on what to have for lunch, said Benjamin Franklin. How many surgeons are in the audience? And how many radiation oncologists? I found one of you who's supporting me. The rest of you seem to be of the thoracic surgery side.
We support you.
I love the support, but let's not forget that sometimes the lambs can have a radiation beam. So watch out. Who was this?
Stalin.
It was Stalin. And Stalin is noted to have said, it's not the people who vote that count, it's the people who count the votes. Let's have a round of applause for our judges before we go further. Excuse me, you're not allowed to speak. The data is clear. Overall survival appears better with resection, as has been said. The survival data there from multiple studies do support surgery. In fact, surgery is diagnostic, is it not? No meet, no treat, right? And surgery's been around for much longer. This picture from Hopkins, where I serve on the faculty, shows Halstead, who was doing surgery long before any of us were alive. So indeed, I think our surgeons have a point. Surgery seems to win out. The survival is better. It's been around longer. And of course, it's diagnostic, as has been said. This, by the way, is a picture of the first photobombing. And this is a radiation oncologist. So, you've won. We should congratulate them, should we not? Actually, you've lost. I've already won, and I've won because I'm speaking toward surgeons primarily, and the fact we're even debating sublobar resection versus radiation speaks to the threat that radiation is. It speaks to the fact that we're having a national debate about a migration of therapy away from surgery and to SBRT. That speaks to a win right there in and of itself. In fact, the problem is that too many of us see the world as nails because we're hammers. The end. So I ask, is overall survival the right endpoint? Well, when I sit in my tumor boards, here's how it goes. Ms. Jones has a lesion. Would you like to remove it? No, she's frail, she's old. Her pulmonary function will never make it through surgery. Russ, why don't you give her radiation, okay? Yes, sir. And so this retrospective data that we've seen is so biased in the way the retrospective data can be. In fact, my colleague Ira Grills looked at this lobectomy versus wedge, and she showed that although the overall survival does support surgery, the local recurrence supports radiosurgery with no difference in cancer-specific survival. There's only 2 studies in the literature that look at overall survival in medically operable patients, and they both show an overall survival of 84%. Shall we compare that to the surgical literature? Shall we?
Yes.
Well, let's look at LCSG821, who showed at 2 and 3 years respectively that the survival was around 80%. This more recent study showed survival at 2 and 3 years, well, actually looking a little worse than radiation. In the absence of randomized data, we need to focus on primary control, not on survival, because survival is biased. And so when we look at local control, we see with radiation control rates of 85 to 95%. And how do these compare with sublobar resection? Well, let's look. At 2 and 3 years, the data that we were looking at, 80 to 85%. At 7 years, which is what this study reported out at the bottom, 92% with radiation, and well, LCSG didn't even go out that far. So we really don't know, but we know that it's under 50%. So outcomes for radiation aren't mature, right? That's why we need to do surgery. This is an untested medication, but it included a lab rat. LCSG never reported past 4.5 years. There's no long-term data for it. So do we not accept that data because they didn't report after 4.5 years? I don't think so. Well, what about toxicity? We found a mass. The good news is we found a weapon of mass destruction to help take care of it. The weapon of mass destruction sits at that table over there. Toxicity, looking at 30 and 90-day mortality by age, shows that in younger patients, 50 and 60 years of age, that there is no difference in 30 and 90-day mortality. But as a person ages, on average, this data reported last year, shows a reduction in outcome with surgery. With matched comparison, 30-day mortality 2.4% versus 0.8. Pulmonary function change shows a lasting change that supports the use of radiation over surgery in a statistically meaningful way in a non-thoracic surgery journal. What about the pooled result of STARS and Russel? 58 patients. We won't even look at the survival data, will we? Because that paper's crap. And you know. Well, but this is absolute crap. Excuse me. I am the one presenting, not you. The fact of the matter is there were 60 patients, half had surgery and half had radiation. Let's look at grade 3 or greater toxicity. Maybe in your world these numbers are the same, but in mine they're pretty different. What about cost? This is a study that looked at the cost of care. $55,000 versus $77,000 for 5-year cost. And so when we look at these things, a diagnostic tool, as has been pointed out, surgery wins out. Overall survival, no question, surgery wins out. Local control, I don't think so. We have equal outcomes. What about toxicity? Despite the fact that the surgeon who loves to have his own body operated on thinks that works well, toxicity favors SBRT. Cost favors SBRT. What about the abscopal effect? Which most of you surgeons missed to talk this morning about it. That would favor SBRT. And what about the future? Well, if we look at diagnostic tools like liquid biopsies, ooh, what happened to surgery there? What about randomized data? Ooh, And so I played for all of us to all of our patients to support the following 3 randomized studies. In essence, we need randomized data, and there is not a broad brush that should be used. There's no one right answer for all of the population. We need to give our patients a share in the decision-making process. If surgeons are not having their patients who are borderline resectable meet with radiation oncologists, they're missing an opportunity. If you're so convinced your therapy is better, then have them meet with a surgeon and a radiation oncologist together. That's what we do at Johns Hopkins. We have to be ardent advocates for our patients, and when they win, we all win in the future. And so I close with the question of, is there equipoise? Absolutely there's equipoise. Let's not forget what Abraham Lincoln said. The problem with quotes found on the internet is that they're often not true. Thank you very much.
We will have a 3-minute break while you prepare for your rebuttal. Meanwhile, let me go and threaten the judges.
Actually, I was told to have something to talk only 2 minutes ago. But as a handsome and gentleman surgeon here, so among all the gentlemen and handsome surgeons, I believe surgery still will be the first choice for early-stage lung cancer, especially GGOs. Because as we know, tissue is always the issue. However, SBRT could not solve this issue. Yeah, so we need to get more tissue. Every time when I have some nodules that couldn't be diagnosed by biopsy, I ask my radiation colleagues, they'll say, oh, just cook it. Yes, but that's not the way it goes, right? Yeah. Sorry? I think I need to talk like this. Yeah, something like that. And nobody will know who am I. Yes. And I'm so lucky that I don't have a colleague last month like you. Yeah. So in my hospital or in my situation, I always win. Yeah. Yes. So again, I think the most important thing is that we cannot compare banana to apples. Yeah, because we treat cancers after we get diagnosis. But SBRT, you treat tumors, but you pretend it is cancer. But maybe it is not, and that's my opinion. So, last but not least, so I think surgery still the first choice for early stage lung cancer. in medical patients. Thank you.
I'm Guillermo from Japan. So I think that I had some advantage of sub lobar section. One is the indication of sub lobar section is more wide because the GGN region located near the aorta or mediastinus thoracis or pulmonary vessels, we can do the SBRT because some injury it may be occurred. The second is intraoperative lymph node assessment can be done by sublobar section, especially segmentectomy. So we need to combat the intraoperative higher node positive cases. We need to combat the lobectomy because the lobectomy with lymph node dissection is a standard procedure for early stage lung cancer. This is the second reason. Finally, after the SBRT, we need to more perform the CT follow-up because of the pneumonia after SBRT is one more common problem. But after the sublobar session, we need to do a more close follow-up. For example, every 1 year by CT. It's very long-term follow-up period. So these three regions is I think the subglobalization is superior than SBRT. Thank you.
So maybe we can finish. You don't need to debate, right?
Time for rebuttal, Russel.
Is it too late to sign up for a thoracic surgery residency?
You're always welcome.
Hey, thank you. No, in fact, I'll make a wager to you. Let's make a wager. We'll make the wager that when the randomized data comes out, if it's in favor of radiation, you invite me as a guest professor to your university to present the data. And if the data supports surgery, I'll invite you to Johns Hopkins as a guest professor to present the data to our team there. Are we on for the deal? I think that that's a fair deal. Listen, if our surgeons think that it's justifiable to take a patient to surgery who has no tissue diagnosis and take out part or all of a lobe on the rationale that it's a diagnostic procedure, it certainly seems reasonable to me that it's justifiable to treat these lesions without a tissue diagnosis if they're high risk, because the risk of the diagnostic procedure is as high or higher than the risk of the therapeutic procedure. In fact, 80% of people in Europe do this right now. 80% of tumors in Europe are not biopsied before getting SBRT. And so I actually think that the whole issue of tissue as the issue is actually not going to matter in about 5 or 8 years when we're just able to do liquid assessment on these tumors anyway. I think the data speaks for itself, and I think that our esteemed jury will find that to be the case as well. I have nothing else to say until I change my mind.
We should all give a very big hand for both of you.
Aneez, we have one more colleague who hasn't talked. Yes, as a surgeon, we should be generous. Yes. We should let everybody talk. But only 2 seconds, okay?
Thank you and goodbye.
Well, so the 2 things that I want to add to this fantastic debate, as the pulmonologist who does biopsies for a living, to be told that the biopsy is an unnecessary procedure, if I'm offensive. No, just kidding. But this whole debate is of a moot point, because with robotic endoscopy and the ability to do microwave ablation, I'm going to put both of you out of business.
Yeah, absolutely. Because you know, I was actually threatened before I came here. So you had Aneez coming and saying, so he's a threatened pulmonologist. I think the surgeons are already feeling very threatened, and I think that you are going to be in their seat in a couple of years, because we are going to approach all these nodules, biopsy them, and ablate them, like Kyle said. But the fact of the matter is, both speakers have put a very strong case, but both of them are talking about doing it without biopsies, and therefore, it will be Mrs. Jones who will decide what she wants for her. And you know, so as you said, it is her decision eventually as to what she wants. If she's an 80-year-old frail lady, well then yes, she goes to the left corner in the red. And if it's a healthy young male who has some such situation, and he doesn't mind getting himself operated, like he had his leg, then it goes to the blue corner.
When you said Mrs. Jones, you meant the third judge.
I may look like a woman with this wig here. I certainly can sing some great songs like I Feel Like a Woman. You make me feel like a natural woman. It's raining men.
Winter is coming.
Yes. But I just want to make a comment. My esteemed colleagues here talked about the future. My esteemed colleagues talked about the present. And I felt that it was true. Lincoln is ahead of his time. He made predictions about the internet and books. It was interesting that the lamb felt threatened by 2 wolves. And I assume that the hungry wolves just were presumed to be carnivores and the lamb was the meal. And I noticed that the person who felt the most threatened was the lamb as they pulled out that gun, reminding me that they protested a little bit too much. Now, based on that argument in a very famous movie, I just think that we should leave the gun, take the cannoli, the cannoli being the tumor in the nose, and based on that fact, I salute you, my friend, and surgery.
The rest of the dinner.